Welcome to the Researched RN podcast. I am your host, Steven Cuzmenco. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In this fifth episode, I'll talk about an article published in Geriatric Nursing titled Fundamentals of End-of-Life Communication as Part of Advanced Care Planning for Older People, an interview study with nursing staff. It's authored by Peerboom and colleagues. So to start off with the background of this, before we get into the actual study, end-of-life communication. This is something that nearly all nurses will experience at some point in their career, and of course, hugely influenced by their work setting. So when you think about nurses in the ICU, or maybe they work in oncology, they might be having these conversations more often than nurses that work in long-term rehabilitation or home health settings. Advanced care planning emphasizes the proactive discussion of end-of-life care preferences between older patients, their families, and healthcare providers. It's a way for people to decide, this is what I'm going to want to do later in life or at the end of my life, and I'm in a capacity to answer it now. Nurses, unfortunately, when it comes to these types of conversations or end-of-life conversations, they express discomfort and a lack of training on the timing, what these conversations need to be like, and their role in the care team when it comes to end-of-life communication. This type of communication is really important for nurses to be able to do because it can allow older people, as I mentioned, to take that proactive role and make those decisions about their own future. And it's super important that they do that when they have the capacity to answer questions and actually communicate their preferences. There has been research in the general fundamentals of what end-of-life communication should look like and the things that are required for it to be effective. But these researchers wanted to gain a deeper understanding of the content of the fundamentals of end-of-life communication. It's important that we understand the fundamentals of end-of-life communication because we should be having it sooner, not later. You always hear about people, or you may have heard people say that by the time you get to the hospital, if you haven't had a conversation about end-of-life, it's too late. You want to try to do it as soon as possible when the person has the capacity to do so. So the authors really want this study to occur because they think that the results of it could help develop a theoretical framework that enables staff to get educated and informs healthcare workers in how to support themselves and their colleagues in performing this type of communication in practice settings effectively. And so finally, moving on into the study methodology and objectives, the purpose of this study was to, quote, gain an in-depth understanding of the fundamentals of end-of-life communication with older people as part of advanced care planning in home care, nursing home, and hospital settings from the perspective of nursing staff. It's interesting. They didn't ask the patients or family members. They really wanted to understand this type of communication from the perspective of the people that are implementing or initiating these conversations. It was a qualitative approach these researchers took by implementing semi-structured interviews with nursing professionals in the south of the Netherlands. Nursing professionals that were included were any that had a conversation on end-of-life care or death and dying in the 6 to 8 weeks prior to the scheduled interviews. And they were particular to have these conversations with older people. And older people were defined as individuals over 65 years of age and receiving palliative care in the aforementioned settings, home care, nursing home, and hospital settings. With this sample, there was no randomization. Instead, they used purposive sampling, which is what they say allowed them to have a variety of professions, education levels, and years of experience included in the sample. The interviews occurred between June of 2023 and December of 2023. And so we get into the results or the key findings in the overall themes of end-of-life communication. So 17 nursing professionals were interviewed. The average length of each interview was just over an hour, and there were 5 themes that came from this and 19 fundamental concepts, and each of them kind of is attributed to each theme. And so here are the 5 themes. The first one was feeling comfortable. The second one was creating space for open communication. The third, using senses and applying communication techniques. The fourth was following the conversational phases. And the fifth, being aware of interprofessional collaboration. The first and second themes were related to the preconditions that lead up to the end-of-life communication. The third and fourth theme were related to actually performing the communication itself. And the fifth theme was related to the overall process, implementation, who does what part. And so let's talk about each of these themes, and I will briefly touch on the 19 fundamentals that were attributed to each one. So the first theme, feeling comfortable. There were 3 fundamentals that were associated with this theme, and this theme was actually considered the most important precondition, as the nursing professionals explained in their interviews, for engaging in end-of-life communication. We must feel comfortable with each other in order to communicate about end of life. And the 3 fundamentals were the ability to communicate about the end of life, learning by doing, and establishing a trusting relationship. The first fundamental in the first theme, ability to communicate. We must feel comfortable and we must be aware of our own values and beliefs and cultural backgrounds, because that helps us understand what we can bring to the conversation with that older person. And also, if we feel comfortable just on an emotional level, leading up to that conversation really influences how well we will do. And so some of the things that they said was whether or not it's appropriate to show emotion in front of the person. And I'll talk about this later on, but essentially, do you do that yourself? If you feel sad about their situation, do you show that? Do you cry with them? Some say that contributed to the humanity and openness of the conversation. And then some thought it was considered unprofessional. And so that kind of leads us into the second fundamental of establishing a trusting relationship, which really depends on what they say is interpretation of observations and what they see the older person experiencing, so that they can then mirror and reflect that, because that allows for an intimate conversation to be established. So creating a sense of humor, maybe saying a joke, or demonstrating expertise and confidence were some of the main ways that they were able to establish a trusting relationship. And the other thing that did help was being older as well, having an older age similar to the older patient, that they said that reflect greater life experience, which helped them connect on a deeper level and trust from the patient or the older person. Some of the other strategies that the nursing staff mentioned that helps them establish this trusting relationship is being more direct and forthcoming, expressing emotions and displaying interest, as well as demonstrating trust and initiating conversations amongst the other nursing staff. So if there was a nurse and a nurse aide that walked in the room, that dynamic between those two professionals kind of helped the older patients see them in a better light. And then the last fundamental in theme 1 was learning by doing. So some of the younger nurses and healthcare professionals didn't really agree with the older staff. Really, it comes down to experience. But unfortunately, the younger staff didn't have that. And so they felt that education and training was helpful in understanding how this communication should occur, what are the things that need to be talked about. But the older staff really felt like the book knowledge didn't help as much as the real life experience, whether that's professional experience or personal experience. This starts to highlight the overall theme of how we have to move with the patient, is what they kind of say. And the conversation has to be dynamic. And of course, this is something that if you just remember a list of facts, it's kind of hard to do. So this is why they say that you just have to have experience having really good end-of-life conversations and having really bad ones. And then you pull from that and you get better. And it's the repetition that helps you have more effective conversations at the end of life. Theme 2, this was the longest theme that had 5 fundamentals. Theme 2 was creating space for open communication. And I think this one was definitely one of the most practical themes and the fundamentals here. So if I really hope you do read this article, I really like this theme. Again, the first 2 were leading up to the conversation. So theme 2 is leading up to the conversation. How do we create a space for open communication? We have to move along with the older person. What does that mean? Each conversation is going to be dynamic, and we have to go in knowing that, hey, this conversation may not go the way I want it to. We can try to have a structure to this conversation, but we really want to understand how this person feels about where their life is going, and that will help us make the decision, the more technical and medical decision about what they will agree upon. And so moving along with the older person, that was the first fundamental, just having this mentality that the conversation is going to have to change, and the way that you end the conversation will likely not be the way that you started the conversation. The second fundamental under theme 2 was being easily approachable. So we need to be empathetic, compassionate, and respectful. Those were 3 characteristics that the nursing staff, they said, that were key in being approachable. We can express compassion by being near the older person, placing a hand on their shoulder, holding their hand, or hugging them. Also, addressing the older person by their first name, of course, with permission, and sitting down beside them, or kind of getting to their level. Don't stand and tower over them. Getting down to their level, sitting down, and then giving them space and time to share their stories. This may not always be possible to give them time, but this really does help establish that sense of empathy and compassion and respect. And then matching the verbal tone to the patient, the older person, is also really important. And the third fundamental in this second theme was creating a calm atmosphere. This can be challenging, but this really has to do with who's in the room, how are we speaking, the volume of how we're speaking. Can we close the door or the curtains? Are there any distractions and music or TVs? And so we really want to try to focus in on the conversation and make that known as the reason why we're there. We are there for that person, to help that person through their condition and help them make a decision. The fourth fundamental was taking a seat. I kind of mentioned this in the second theme when it comes to being easily approachable, but just sitting down next to the person the staff interviewed really felt like this helps show that the older person is equal to the healthcare professional, which encourages conversation. But even though the nursing staff did admit this in their interviews, they did say that they don't always do that because of time constraints. Maybe they have other people they have to look at, or they have to visit another patient, or their colleagues need help, or they need to take a lunch, or the shift is almost over, or medications are due. So there's obviously a number of reasons why time is really a barrier to being able to do this. But if you have the opportunity to, taking a seat is going to help. And then the last fundamental in theme 2 was just being honest. Being direct and communicating honestly was very important, especially when it comes to the urgency of the conversation in the instances that acute deterioration is occurring or the patient is now admitted to a hospital. And so they really emphasized how we just need to be direct and honest with them and let them know their options so that their wishes can be adhered to as much as possible in the situation that they're in. Especially in hospital settings, conversations have to happen much quicker than we want them to in some instances. And so the earlier, of course, this happens, the better. But regardless of the situation, being direct and honest was vital. The third theme, using senses and applying communication techniques. And so now we're moving into the implementation of the end-of-life communication. The first one was listening. So we have to listen to what they say, but it's not just hearing what they say, but actually listening and paying attention. This is important for advanced care planning. And the theme I guess the strategy that came up was what they call filtering. The staff said that when they're filtering, they are listening to topics that are important to the older person, and then they emphasize those and they go with the flow or go with the person in that conversation, follow them along. And that not only shows the person that they're listening, but it's an effective communication technique in this situation, primarily because we're talking about end of life. So they can really get to the core of that person and help them understand why they want to live longer or why they don't want to live longer. It also shows that you were listening, and that can also contribute to a more trusting relationship with the older person because they know, oh, wow, you really did hear what I said earlier or last week, and now you're bringing this up again. That is something that older people may really appreciate. The second fundamental in theme 3 was seeing. This has to do with the intonation, the nonverbal communication, body language, facial expressions, and maybe how they look. How are they looking at you or vice versa? These expressions can help healthcare providers recognize agitation, fear, sadness, misunderstanding, and resistance. In the interviews, they stress the importance of verifying these perceived signals. So you see this happening, and let me verify by asking, I have the idea that you are fearful. Is that true? I'm seeing this. And by doing so, by kind of not necessarily calling them out, but just verifying your observations by asking the person, if it's appropriate, of course, because this is a dynamic conversation that can change, but sometimes older people may not even know what they're doing, how their nonverbal communication is being perceived. And so when nursing staff verified that by asking them in a really compassionate, respectful way, that also established trust and helped the nursing professional understand how they felt. The third fundamental in theme 3 was speaking. So of course, we have to be fluent in the language of our patients, but it's not just about the language, it's about the terms that are used and the way that we are speaking. And so to avoid misunderstandings, the nursing professional said that they try to avoid difficult words. Highly technical medical words could be an example of this, and to speak in concise sentences, but also allow for pauses in between their sentences so that the older person has time to think or process, react, vent, whatever it may be. And then once that occurred, whether they responded or not, the nursing professionals also reported using teachback, which is a very well-established teaching strategy. It allows the older person to summarize what they understand about the conversation or whatever their condition is. Overall, the nursing staff said that we want to try to promote awareness and get the most understanding through to the person during the conversation rather than after the conversation. Because how many times is it that you might go into the room with a patient and maybe the physician's in the room and things are talked about very quickly and there's no time to process, and then you get any questions and nothing, no questions. And then 5 minutes after whoever leaves the room, the provider, nurse practitioner, now the patient starts having questions. And so, well, they just left and you didn't have any questions. You have to get them back, or you have to try to answer to the best of your ability. And so being able to do that in the conversation, speaking to them in a really understandable way with pauses, is a great way to avoid any misunderstandings and get the message across. The last fundamental in theme 3 was about intuition. This one was the hardest one for the staff to really verbalize. They didn't really know how to make this in a tangible, practical form. And so when you read this paragraph, the description of this is actually really short, but it comes down to approaching conversations based on their own feelings, the feelings of the patient or caregiver, which allows them to use their intuition. It's something that's intangible, but really a prerequisite to having effective communication, really. And you can actually make the argument really in any context. But of course, we're talking about end-of-life communication. Now, the fourth theme, following the conversational phases. So there were 4 phases to the conversation. The first one was preparing for the conversation, especially informal ones, because we have formal and informal. Formal being, this is planned, there's an agenda, there's an outline, there's kind of an end game to what this conversation should finish as. And then informal were impromptu, unplanned, shorter. Maybe there's no agenda or a structure, but we must be prepared for the conversation. There was a disconnect based on age in this fundamental, whereas younger staff liked to be informed of past communication, the reason for the current conversation, who the older person was, the emotional state of the person, and maybe even reading through the medical record and or talking to other colleagues who know that person. But the experienced staff said that complete preparation is not going to be enough. You really cannot prepare fully. This thought that you can be prepared for these types of communication really almost seemed like something that can't be attained. And that's because the conversations are dynamic in nature. Yes, there could be in the case of formal end-of-life communication, there could be an outline or set questions that we want to make sure are answered, but you're still doing all the things that we talked about, especially in the prior themes, listening to the person, filtering the nonverbal communication cues, reflecting teach back, asking them, hey, I'm seeing this. Is that true? So that might force you to shift the conversation. The second fundamental in the fourth theme was initiating the conversation. So some said that a formal conversation could be in response to deterioration or admission. And so there's this expectation that this really does need to happen. But sometimes these conversations can be initiated if the older person gives a signal. This could be some form of sadness or worrying, having questions about a particular treatment, or deterioration, which, could be all sorts of deterioration, spiritual, emotional, physical, mental. Seeing that, observing that might be a cue. I might need to talk to them and start this conversation. The third fundamental in theme 4 was gently building up the conversation. And so this really highlights the reality that these are conversations that are dynamic. They should not be, or they cannot be, very structured. And it's almost, if you get into it too quickly when the person's not ready, then it could impair how open they are or how well they trust that nursing staff professional. We really have to rely on the person's signals and cues. And then based on the answers or the verbal or nonverbal cues, the nursing staff member ask follow-up questions. And I mentioned filtering earlier, which has to do with picking out the reasons or things that are important to the older person and bringing that up later on so that they can understand how they're feeling and kind of the decision that they are leaning towards. I liked that they said the questions that they ask, these follow-up questions, are considered bridging questions in response to what the older person says. So it kind of allows them to keep getting to the topic of what decision do you think you're going to make, but it's not so direct. We gently get there. We don't want to force that. We want to make sure that the older person knows that we respect their dignity, and we want them to make this decision with all the facts, and we want to give them time to understand that. And so the other thing that kind of goes along with that is how, even though we do want to get to that end game, building up to the conversation, one of the things that could help is that older people do not have to make the decision instantly during the conversation or even in that same conversation. Of course, remember we said that there were follow-up conversations. They don't have to be made instantly during the conversations, and decisions that they make are not unchangeable. If they make a decision about something and then later on they decide something else, then that is completely acceptable. The fourth and final fundamental of theme 4 was evaluating and following up on the conversation. This typically happened immediately after the conversation, but if the conversation was difficult or particularly challenging, then they could evaluate the conversation later, even a few hours later, or maybe a couple days later, just to give that person some time to calm down, to have processed that information. But before they ended the conversation, the staff said that it would be okay to have a follow-up conversation regarding what we talked about, which helped them build a trusting relationship and also allowed them to bring it up again so that the person is ready for it. The final theme was about being aware of interprofessional collaboration. And there were 3 fundamentals when it comes to interprofessional collaboration. The first being perceiving your professional role. In these interviews, a lot of the nursing staff members had difficulty describing their particular role in end-of-life communication. And remember that they interviewed registered nurses, nurse practitioners, and nurse aides. The staff members saw themselves as someone who coaches, empowers, informs, makes the older person think, and can even help structure the older person's thoughts as it pertains to end-of-life communication. The types of end-of-life conversations between the specialties was different. So nurse practitioners really honed in on the treatment when it comes to end of life, and they did so in formal conversations. And that contrasted with the nurse aides, who they mostly engaged in informal conversations and usually only asked about what was important to the person, how they felt, their mindset for that day. They didn't really feel like it was their place to talk about treatment. And nurses engaged in both formal and informal, and a lot of times with other people. These conversations were not alone. They had them with another colleague in the room, whereas nurse practitioners and nurse aides, they engage in these conversations alone more often than not. And there was also, based on not only specialty, but work setting, home nurses engaged in end-of-life conversations that looked more into the future than nursing staff that worked in hospitals and nursing homes, because in these settings, the life expectancy of that person is not as long as when they're living at home, at least in a normal situation. The second fundamental was involving other colleagues. So in these interviews, the nursing staff actually mentioned how curious they are of the opinions of their colleagues. They actually really wanted to know what they thought about the conversation or their approach before they went in, or how they did afterwards. That could be a good way to debrief after a nurse or nurse aide has a conversation. They can actually reflect on their performance and what their findings were, not only from a professional but a personal standpoint, so that they can then do that again. They can grow to be able to do that again. And this could be especially important if the conversation was really challenging, there was resistance, especially unexpected resistance, or a difficult topic was discussed. And then the last fundamental in the final theme was involving caregivers. The nursing staff interviewed said that we should involve the caregivers because that allows them to get more information from the patient about the patient, but also helps them have that shared decision-making in the end-of-life process. But nursing staff were clear that the older person, the patient, should be in the lead in the conversation, and they really have the final say as to what the final decision that is made. And they helped accomplish this by asking questions directly to the older person. And especially if there were instances where the conversations were dominated by the caregiver, or if opinions were held that conflicted the older person, or if they just outright disagreed amongst other family members, that is where, well, let's go back to the patient. Let's see what their wishes are. Let's see what their understanding is, and help them come to the conclusion as to what decision they will make. And those were the 5 themes. And all of the fundamentals, at least some snippet on the fundamentals, that were associated with each theme. And so now we can move on to the discussion. I'll summarize the discussion, and really I'll just summarize what I thought were the most interesting points. You got to go read this article yourself. I'm just going to tell you what I thought was the most interesting. I felt like I was not really attuned to the importance of using our senses and those associative communication techniques, which allows you to follow the conversational phases. Going with that person, that to me was really cool. Something that I hadn't really, I guess I had done it in my experience, but I hadn't really put a name to it. The concept of, hey, this conversation is going to be dynamic. Have I gone into conversations with patients and I had the mindset that we're going to talk about X, Y, and Z and we will get the answer? Well, but it's not a formula. And so I think this study really helped me see that we shouldn't be going into these conversations with a very strict agenda. Sure, can we have a topic or a couple questions in mind? Yes. But as that conversation starts to unravel, we filter, we see, we listen, we observe, and we ask what they're feeling, and we give them time to process. The conversation will shift. And so we have to be prepared for this dynamic conversation. The other thing that I really thought was important was the interprofessional collaboration. We really can lean on our strengths and maybe communicate more amongst each other. This wasn't said in the interviews, but I really do think that based on how they told the researchers what their role was, it seems like this happens in silos. This type of communication happens in silos. So what I mean by that is, the nurse aide goes into the room to check on the person, and then something might happen there. And the nurse practitioner, it's the start of the day and they're rounding and they have a formal, scheduled, structured conversation and there's an end goal in mind. And the nurse may or not be present. The nurse aide also may or may not be present. And then the nurse goes into the room and asks them, oh, hey, what did they talk to you about? And then they continue that conversation. But I don't know if these three professionals are ever coming together, all three at the same time, and really talking about, hey, this is what I'm seeing. This is what I'm getting from them. What about you? What have you talked about? I don't know. Maybe this is my misconception or misperception, but I think that we could probably do better at collaborating with each other and having more conversations professional to professional instead of having this siloed approach and having informal conversations here and never following up with our other colleagues about what we're finding. It sometimes, really it does kind of fall on the nurse, unfortunately, to be that translator, to be that intermediary between professionals. But I think maybe, something that we can think about is maybe a debrief, after they have these conversations, or the nurse practitioners asking more about the nurse aides. Hey, you are in and out all the time. What do you think about this person? What have they told you? I think having those conversations professional to professional could help. The other thing that I thought was really interesting and practical, they mentioned this in the debrief, is just this whole thought of relinquishing control, letting go of what we want to get out of the conversation and approaching it and saying, I'm going to explore this person's values, this person's life goals, and their wishes. And I'm not going to try to dominate the conversation and lead them where I want them to. I'm going to let them get there on their time. And so this comes down to what they say has to do with experience. If you have less experience with this type of communication, this might be more of a challenge. It might be harder for you to get there. You might have to understand the actual techniques. But with experience, the staff said that they move along with the older person. They develop this connection with them. They are able to better use their senses and intuition to allow for more engaging and person-centered communications rather than memorizing the models and the frameworks, which helps them prepare for future conversations. It also almost, to me, it's almost like a little bit less stressful when you just go in with that mentality that, hey, I'm not going to have this expectation of what I want to get out of this conversation. I'm going to help them get there, or I'm going to help them where they are, or evaluate their understanding. I think that it's kind of freeing in a way. Of course, it could be more time consuming. If you're being less direct and you're kind of guiding that person there, you're helping them get to where they want to get. But I think that helps us have a mentality even going into the conversation. This idea of having an agenda in advance. Some of the staff said that was important. Some said that it wasn't. Say, don't have an agenda. You got to be flexible. Other people want it to be structured. So, there's going to be differences in how we approach nursing care, our communication strategies, but it's something for you to consider yourself, I think. I also found it interesting that some of the staff members said it was inappropriate to express their emotions. They felt like this was unprofessional, but then there was a divide. Other staff members thought that it could actually help to the humanity of the conversation and help build trust, help open that older person to the subject matter and maybe connect a little bit more. So I personally feel like it's okay to show emotion. I did at times, especially what we're talking about now, end of life. I gave family members hugs, at least a handshake or put my hand on their shoulder. And I felt like that was okay. I think that showed that we are humans and we, of course, want people to live, but we also want people to have the quality of life that they deserve or they want in their own life. Those were some of the major discussion points that I wanted to summarize. This study did have a lot of strengths. It provided a richer understanding of the fundamentals of end-of-life communication. We knew of the themes and kind of what end-of-life communication should entail, but these fundamentals, these strategies, I think this study really helped put them in a practical format so that you better understand how you should approach these types of conversations. Some of the limitations for this study, the first being that, none of the staff members were randomized. This was a purposive sampling. To me, it sounds like convenience sampling, but maybe asking people more directly, hey, can you be in this study? It was people that considered themselves proficient and comfortable in this. So what about people that aren't proficient and comfortable in it? What is their approach to end-of-life communication, or do they even have an approach? Maybe they need to read this article. Another limitation for this study was that factors such as cultural diversity were not mentioned or talked about. And so the differences between the cultures of the nursing professionals and the patient, they did not intentionally ask questions. The interview questions that they asked are actually listed in the article. It's in one of the charts. And the other thing that wasn't really involved in this study is this was an interview-based study on the nursing professionals. There were no questions asked from patients or family members on what they think is effective end-of-life communication. So, of course, there is a whole other person that we have to understand. This was really limited to the perspective and the experience of the nursing professional, whether that's, of course, the nurse practitioner, the registered nurse, or the nurse aide. And so as we wrap up this 5th episode of the Researched RN podcast, firstly, I want to say thank you for listening. Thank you for sharing this podcast. Please do so with anyone that you think will be helpful. I'd also really encourage you to actually read this article and look at the main aspects of end-of-life communication, the themes that were identified and the fundamentals, and understand what these are and really work towards implementing them. I think that a lot of these, the way that they framed this in the article was very practical. And there's a lot that I didn't cover. There's a whole page on the actual quotes that the nursing professionals said in regards to each of the fundamentals. That's how they were able to identify the themes, the overall themes. So I'm sure you can get a lot more out of reading this article rather than just hearing me talk about it. So please go read it. And that is a wrap on the 5th episode of the Researched RN podcast, your virtual journal club on the go. I am your host, Steven Cuzmenco. I'll have episodes out at least monthly, and you can email me at researchedrnpodcast@gmail.com with any articles or topics you'd like for me to discuss. Thanks for listening, and be sure to tune in to the next episode.